Now we are going to talk about the immunosuppressants. These are the agents that block lymphocyte activation and proliferation. They reduce the acute transplant rejection by suppressing cellular immunity by used at prophylaxis. Frequently combined to achieve greater efficacy with decreased toxicity. And chronic suppression increases the risk of infection and malignancy. Most commonly, for the immune suppression, we are going to use NSAIDs or steroids. And less commonly used drugs are Cyclosporine, Tacrolimus, Sirolimus, and many more. So before we are going toward specific drugs, please focus on this diagram. In this diagram, we are going to block 5 places on the 5 poles. First in calcineuron, this one. First in calcineuron. The third, we are going to block NFKB. Third, we are going to block mTOR. For IMP dehydrogenase and PRP amidotransferase. These 5 places we are going to block for the inactivation of T cell or immune suppression. First, we are going to start with cyclosporine. The cyclosporine is a calcineurin inhibitor. What is a calcineurin? The calcineurin is a substance that is going to active by the cyclophilin on FKBP. For the activation of calcineurin by the cyclophilin, we are going to block by cyclosporine. So there will be no formation of NF-AT, that is formed by the dephosphorylation of MF-AT. I'm going to do the transcription of a DNA, and further it will result in production of inflammatory cytokine genes. By that we will decrease the IL-2 expression and also will decrease the production of cytokines or inflammatory mediators. Second, we are having Tacrolimus. The Tacrolimus also going to block FKB. The FKB also join with the calcineurin and make this pathway and take the formation of NF-AT. They will go and do the transcription and make the production of inflammatory cytokines. We can block this calcineurin by the 2 pathways by blocking cyclophilin or FKBP. The FKBP is going to block by tacrolimus and cyclophilin is going to block by cyclosporine. Yes. Both drugs are going to inhibit. These both drugs are going to inhibit calcineurin. And this calcineurin exhibits NFTA. Is it going to activate NFTA, NFAT by dephosphorylation as mentioned in the diagram. And NFAT stands for the nuclear factor of activated T cells. And this is important for the transcription factor for the many cytokines that involve in inflammation. Again, I will make a simple diagram here. What is going to happen? The NFAT having phosphate group after the process by the calcineurin, it converts into NFAT, and this NFAT go to the nucleus and it will form interleukin-2 and other cytokines. If we block the pathway from this calcineurin, so it will not convert in NFAT and not go to the nucleus for the transcription, and the interleukin-2 will be not formed, and also other cytokines also did not formed. The cyclosporine is going to bind cyclophilin The complex inactivate the calcineurin, and tacrolimus are going to bind FK506 binding proteins. These are mostly given for the autoimmune diseases, organ transplants, and they both having similar side effects, and both drugs are going to metabolized by P450 system, and the many drug-drug interaction they can have. The most common thing before giving the cyclosporine or tacrolimus, we are going with renal function tests because both of these are going to cause nephrotoxicity. The most important limited side effect of cyclosporine and tacrolimus is a nephrotoxicity due to the vasoconstriction of efferent and efferent arterioles. It can also cause the hypertension, and we have the renal vasoconstriction due to it to water retention and salt intake can be stopped. And diltiazem drug is a drug of choice if there is a hypertension. If the hypertension due to cyclosporine or tacrolimus, we can give diltiazem as a drug of choice. And secondly, that all the thing impairs the cyclosporine metabolism and increase the drug levels. And for treat the hypertension, we allow the lower dose cyclosporine to be used in that patient. We can other go for other side effects. It can be hyperuricemia and the gout. Or they don't mention here, but and they could be hyperuricemia and the gout. They could be hyperglycemia, and neurotoxicity can be there. But if we talk about the cytosporine, they are having some special and unique side effects. They are having some unique side effects that are gingival hyperplasia and erotism that can be shown in tacrolimus. The tacrolimus did not do gingival hyperplasia and erotism. Both calcineurin and inhibitors are highly nephrotoxic, especially in the higher doses or in the patient with decrease in renal function. So the function having renal failure, the patient having the renal failure, we did not prescribe cyclosporine and tacrolimus for the immunosuppression. Our next drug is Sirolimus. We also said rapamycin. It is going to inhibit mTOR. mTOR is a mechanistic target of rapamycin, and we can use it for the kidney transplant and drug elevating stents. Like already I told here, we are going to block calcineurin, NFKB, mTOR, IMP dehydrogenase, PRPP amino transferase. mTOR are going to be inhibited by Sirolimus rapamycin. If you study here about this, if it will block T cell activation and B cell differentiation by preventing the response interleukin 2. If you guys know, interleukin 2 is a main stimulus for the activation of T cell. And also it used for the kidney transplant detection prophylaxis, especially in the cell Basil's kidney transplant. If we talk about the toxicity of Sirolimus, there is a pancytopenia, insulin-resistant hyperlipidemia. It did not cause nephrotoxicity as compared to cyclosporine. And it is synergistic with cyclosporine, also using drug elevating stent. We mostly give rapamycin with cyclosporine. Why it is going to this inactivation? Because it blocks the response to interleukin 2 in B and T cells. Also, if you talk about more important thing, they already mentioned also using drug elevating stent. If you guys know about the coronary stents, there are some drugs elevating stents. the strands having a coated with these strands are coated with anti-proliferative drug, and they mean the blunt scar tissue growth restenosis. And mostly the drugs are using there are Sirolimus, rapamycin, already we are going to do Sirolimus, the second Azathioprine and paclitaxel. These are drugs mostly used for the coating of drug-eluting stents. We are having a drug that is the Infliximab. The Infliximab is going to attach with the receptor instead of interleukin-2. It is a monoclonal antibody that blocks the interleukin-2 receptor. Instead of interleukin, it will be replace the interleukin-2 and attach with interleukin-2 receptors instead of interleukin-2. If interleukin-2 did not attach with this receptor, then the signal will not proceed and there will be no other proliferation and differentiation of T cells. And it can cause edema and hypertension and treatment. There is one question, like if we are going to cyclosporine, what are the most cause and risk? You are given the cyclosporine and block the T cell activation by the interleukin-2. So say will be, you guys know interleukin-2 is going to differentiate T helper cell into T helper cell 2. T helper 2 are going to do cytotoxicity. So there will be recurrent viral infection in that patient who are taking cyclosporine, and answer is a high risk of lymphoma due to T cell inactivation. Now we are moving to the next drug, that is Azathioprine. The Azathioprine is used in transplant and autoimmune diseases, and it is used as a product that is converted into 6-mercaptopurine. Mercaptopurine, it is used as a product that converts into 6-mercaptopurine, and it is the analog of hypoxanthine. The analog of hypoxanthine, like purine, like adenine and guanine. So 6-mercaptopurine compete for the binding to HPRT, and this hypoxanthine guanine HGPRT is going to stand for hypoxanthine guanine phosphoriboside transferase, and they convert the hypoxanthine into iosinase monophosphate. There is a hypoxanthine. That hypoxanthine is converting to isonisine monophosphate by the help of HGPRT, that stands for hypoxanthine guanine phosphoriboside transferase, and also guanine to guanosine monophosphate. This HPRT is very important for the formation of hypoxanthine into IMP or also guanine into GMP. Guanine into GMP. And when 6-mercaptopurine, when 6-mercaptopurine are compete for the binding to HPRT, When this drug come and compete with this enzyme, then there will be decrease in purines, and there will be decrease in formation of new RNAs and of then proteins. So it is an anti-metabolite precursor of the same mercaptopurine that inhibit the lymphocyte proliferation by blocking the nucleotide synthesis, and it is used for the rheumatoid arthritis, Crohn's disease, glomerulonephritis, and other autoimmune conditions. And main toxicity called the pancytopenia. If you talk the 6-mercaptopurine degraded by xanthine oxidase, and toxicity increased by allopurinol. Like if you are giving allopurinol with this drug, it will cause the toxicity, and many toxicity will be caused pancytopenia. Other adverse effects are bone marrow suppression. In GI, it can be anorexia, nausea, and vomiting, and you have to use caution with allopurinol because allopurinol do xanthine oxidase inhibitor, and it metabolizes the purine into uric acid that blunt the metabolism of 6-AMP and azathioprine and increase the adverse effects. Now we are moving to our next drug. Our next drug is mycophenolic acid or mycophenolate methylate. It's a reversibly inhibit IMP dehydrogenase, preventing the purine synthesis of B and T cells. They inhibit IMP dehydrogenase, the rate-limiting step in purine synthesis in lymphocytes only. Also preferentially binds the type 2 isoform IMP dehydrogenase. And type 2 expressed by activated lymphocytes. They decrease the nucleotides. They decrease nucleotides. Due to it, they will be decreasing DNA synthesis. In DNA base, due to it, there will be bone marrow suppression and GI nausea, vomiting, and cramp. And if the indication that there will be glucocorticoid sparing agent in rheumatic disease, and toxicity can be caused by upset, pancytopenia, hypertension, and late nephrotoxic and neurotoxicity, and is associated with invasive cytomegalovirus infection. Now we are talking about the glucocorticoids. The glucocorticoids inhibit the NF-κB. They suppress the both B and T cell function by decreasing the transcription of many cytokines and induce T cell apoptosis. When it inhibits the NF-κB, the NF-κB going to decrease the expression of macrophages. The macrophages will be not activated due to decrease the transcription of many cytokines. It decreases the production of pro-inflammatory mediators. Also, it will be decrease the number of eosinophils, or you can say it causes apoptosis of eosinophils, natural killer cells, by decreasing the expression of BCL2, and also increase the concentration of anti-inflammatory mediators. How glucocorticoids are going to decrease the inflammation by increasing the anti-inflammatory mediators like interleukin-10, decrease the macrophage activation, decrease the pro-inflammatory mediators, and increasing the apoptosis of eosinophils by decreasing BCL2 expression. They induce T cell apoptosis, many autoimmune and inflammatory disorder, adrenal insufficiency, and asthma, and they have chronic lymphocyte leukemia, non-Hodgkin lymphoma. And if it causes toxicity, then there could be Cushing syndrome, osteoporosis, hyperglycemia, diabetes, amenorrhea, adrenocortical atrophy, peptic ulcers, psychosis, and cataracts, and avascular necrosis that can be happening if you mourn ahead. Demargination of WBCs cause artificial leukocytosis, And adrenal insufficiency may be developed if drug is stopped abruptly after the chronic use. It can cause adrenal insufficiency because use of long-term steroids. Now we are moving to our recombinant cytokines and clinical use. For example, some person having renal failure, you guys know that Epoetin going to release by the kidney and they having the kidney failure. So for the anemia, especially renal failure, associated with a high risk of hypertension and thromboembolic events, we are going the Epoetin alpha APO analog or Epoetin. That will be stimulate the production of RBCs. Secondly, there is a clonase stimulating factors that will be the names are filgrastim and the circastromotism. That will be go and make the stimulation of the granulocyte clonase stimulating factors and also GMA CSF. It is mostly used for leukopenia, recovery of granulocytes and monocyte counts. The thrombopoietin are used in the autoimmune thrombocytopenia and platelet stimulators, and most common the names are romiflozin and atropropone, that is used for TPO receptor agonist. And for the immunotherapy, we are using interleukin-2. That name is having the aldesleukin, and it is using in renal cell carcinoma and metastatic melanoma. This topic already we done in previous topic, interferons. The interferon alpha is mostly given to patient of the chronic C and the B hypertension, C and the B and renal cell carcinoma. But now we are not preferring interferon due to their side effects. But in previous years we was giving interferons. The interferon beta is given to multiple sclerosis patient and gamma is given to chronic granulomatous disease C, G, D, in which there will be decrease in NADPH oxidase and decrease in respiratory burst, and which infection can be caused with recurrent infection. The catalase positive bacteria can cause recurrent infection. Now we are moving over some anti-cancer drugs like methotrexate. The methotrexate can be used for the chemotherapy and autoimmune. Can be used for the chemotherapy and autoimmune diseases. It mimics the folic acid. It means the folic acid and inhibit and going to inhibit dihydrofolate reductase. Due to there will be decrease formation of folic acid, and methotrexate main side effects are myelosuppression, myelosuppression that can be reversible with the myelosuppression, the side effect of methotrexate, but it can be reversible with leucovorin, that is a folinic acid. That is a folinic acid that converted to THF and does not require dihydrofolate reductase. Can also cause stomatitis, mucositis, mouth sores, and occur with many chemoagents. DNA damage causes cytokine release, and cytokines damage the epithelium due to which they will loss of mucosal integrity and the pain and bacterial growth, and due to which there can be abnormal LFTs and GI can be upset. Second, we are having the cyclophosphamide. The cyclophosphamide is a powerful immunosuppressant, or you can call anti-tumor drug. They're used in vasculitis. And glomerulonephritis, and we can give orally. And it is also having a prodrug that requires a bioactivation. It requires bioactivation by liver and converted to phosphoramide mustard, and that is metabolized by P450 system. It has an alkylating agent that an alkyl group to N7 position and DNA strand with cross-link and inhibit the DNA replication, and due to which there will be cell death of tumor cells. And is also having side effect. See, myelosuppression is a side effect. Side effect is myelosuppression. In myelosuppression, there will be decrease in WBCs, hematocrit, and platelets, and there could be hemorrhagic cystitis, due to which there will be acrolein metabolite toxic to bladder, and that will cause a hematuria that can be having dysuria or not, and they are having a lower list with dehydration and a mesna. The mesna is sodium 2 mercaptonate sulfonate. The mesna bind and inactivate the acrolein in the urine. And second most common side effect is hemorrhagic cystitis. Hemorrhagic cystitis. The second form of SMI can cause SIADH, syndrome of inappropriate ADH, and usually due to IV dosing of chemotherapy that can cause the hyponatremia that will result in possible seizures, and compounded by IVF and complex mechanism that there will be more ADH release and less renal response. Now we are moving towards some others. mAbs. The mAbs stand for the therapeutic antibodies. For the autoimmune disease therapy, the mAb is going to stand for monoclonal antibodies. First, we are having the alemtuzumab. The alemtuzumab is basically going to block CD52, and it is going to use for chronic lymphocyte leukemia and multiple sclerosis. We are having the Rituximab that is going to block CD20, and it is used for the rheumatoid arthritis and chronic lymphocytic leukemia, multiple sclerosis, and lymphoma. We are having bevacizumab. The bevacizumab is going to target the VEGF that is most commonly for the angiogenesis basic cancers, and we are going it for the colorectal cancer, renal cancer, and especially for the small cell lung cancer. And most important point regarding that is it used for new vascular age-related macular edema. So important point which monoclonal antibody is going to use for age-related macular edema. You should know it, the bevacizumab. The bevacizumab is used for the new vascular age-related macular edema. We are having the Cytokine, in which there is the EGFR that is given for the stage 4 colorectal cancers, and also they are giving for head and neck cancers. Next we are having the Trastuzumab. The Trastuzumab mostly in for HER2. If you guys focus, they are having Trans2. They are targeting the HER2 that is responsible for the breast and gastric cancers. Having Tacrolimus going to target CD25, then also used for the relapsing multiple sclerosis. We have in the Immunosuppressant is going to target 2B and the 3B platelet glycoproteins. They can also use for the anti-platelet treatment for the patient undergoing the percutaneous coronary intervention. For percutaneous coronary intervention. We have next is a digoxin immune fab that is given as the antidote for digoxin toxicity. What are the symptoms when any cardiac patient presents with a GI symptom like diarrhea, nauseating, vomiting, and they have abdominal pain? Then you have to give digoxin immune fab. There is one also more drug that is a Monoclonal CD3. The Monoclonal CD3, the monoclonal antibody also called OKT3, and is used in the organ transplantation and it binds to the epsilon change of CD3 T cells. And it blocks the T cell activation and lead to T cell depletion for circulation. And key side effects of this monoclonal CD3 are cytokine release syndrome. Cytokine release syndrome. It occurs after the first and second dose, and they having the fevers, rigors, nausea, vomiting, diarrhea, hypotension, and sometimes chest pain, dyspnea, or the wheezing. Having the pain in the joints, and it can cause by the initial activation of T cells. They release the cytokine and minimize by the pre-medication with steroids and antihistamine. Okay, the cytokine release syndrome can be minimized by pre-treatment with steroids and antihistamine. We are having some more monoclonal antibodies like adalimumab that is target a soluble 200 necrotic alpha. For that, before giving these drugs, we have to do pre-treatment screening of a TB, hepatitis B, C, and viruses due to the risk of reactivation of these things. We have also an intercept that having the decoy tumor necrotic factor alpha receptor and not a monoclonal antibody. It just go and block the tumor necrotic factor alpha receptors. Trastuzumab block the complement protein 5, and you guys know for the late complement deficiency we having the Neisseria infection due to they having the associated increased risk of meningococcal infection. And others are there, but when we are having the Rituximab, the important one, there will be durable PC adhesion and risk of PML in the patient with the GC viruses. And other, you guys go through from it. It's just so important. You have to be remembered all the antibodies, and it's all about the immunology.